The reason why we chose to do this study was treated secondary AML is a very high-risk group with notoriously poor outcomes. Even one of our studies have shown that the survival outcomes are under 6 months. To clarify what is treated secondary AML, so secondary AML itself is something that comes from an antecedent hematological neoplasm or as a result of treatment for any other solid cancer. So what do you mean by treated secondary AML? Treated secondary AML is those patients who have received hypomethylating agents for their antecedent hematological neoplasm like MDS or CMML. This is a particularly poor risk subgroup because we don't have frontline treatment options in this subgroup. Even those studies that did the registration trials for either CPX 351, which is currently approved in the AML secondary to myelodysplastic syndrome, even in that subgroup analysis, what they found was there was no difference between either CPX 351 or 7 and 3 in patients with secondary AML treated with hypomethylating agents. Most recently, we have the approval for azacitidine and Venetoclax in patients not eligible for intensive chemotherapy. Even in that phase 3 study, we did those with treated secondary AML were excluded. So we really don't have any good treatment options in this subgroup. So we sought to analyze to find out if there is an appropriate treatment option in this particular subgroup of treated secondary AML, especially with prior exposure to hypomethylating agents and for their antecedent hematological neoplasm. We did categorize the treatment regimens into 3 subgroups. One is lower intensive chemotherapy, the other one is higher intensive chemotherapy, both without the addition of Venetoclax. And the other group consists of HMA with Venetoclax. What we found was those treated with HMA with Venetoclax did have better response rates and better survival outcomes than those treated without Venetoclax. That being said, the outcomes are universally poor. Definitely, it's significantly improved compared to those treated without Venetoclax. But if you take the outcomes, it's 4.7 months in those treated without Venetoclax. It's 5.8 months in those treated with Venetoclax. This is definitely a poorest subgroup. Then we try to parse out if we can find any difference in the outcomes between karyotypes. We did find that those with adverse risk karyotype had notoriously poor outcomes. Their outcomes were about 3 to 5 months, regardless of the treatment regimen. But in those with non-adverse risk karyotype, what we did find was HMA with Venetoclax did have better response rates and a good overall survival of about 13.7 months in that subgroup. And the other thing was most of the patients, about 1/3 of the patients were able to go to transplant, and those patients who were able to go to transplant did have better outcomes. So in conclusion for this study, we think that addition of Venetoclax to patients already treated with HMA did have better outcomes, especially in those with non-adverse risk karyotype. And we do definitely need better treatment agents in those patients who have adverse risk karyotype. Last but not least, at any point of time when in their first remission, if they could get to stem cell transplant, that should be the goal for these patients.